Good morning. Can you hear me? Yeah. All right. So, yeah. Can you hear me now? Yeah. Uh, we're reaching towards the logical conclusion of the Brainstem series. Now, we're just quickly going to conclude yesterday's lecture with, we're going to spend a few minutes on some important concepts here. And then what's going to happen is Dr. Ulal is going to do a review of some other important parts of the brain. Now, what we were at yesterday was brain herniations. Now, a herniation, a hernia, is basically a visceral organ extending from its usual anatomical place into a place where it doesn't belong. That's basically what a hernia defines. And brain herniations are portents of very bad clinical syndromes. So having a brain herniation means there's something really bad happening there. Now, we have four basic types of herniations, which are all downward herniations from the brain, and there's one which is termed an upward herniation. You don't need to know the details of this, but I just want to tell you to concentrate on one or two important points in this. Now, this is just a representative diagram. Here you can see a mass, probably an epidural hematoma here, and all the herniations are shown here. So this is called the subfalcine herniation, where the herniation of the brain occurs below the forks. The forks cerebri is a dural partition which separates the two halves of the cerebral hemispheres. So that's a subfalcine herniation. You have a transcranial herniation like this. This you see only in trauma or post-operatively. And this doesn't imply much except that there's, it sometimes needs to be repaired. The really bad ones are the uncal herniation, which you're already familiar with. Uncal herniation happens whenever there's a mass lesion on one side of the cerebral hemisphere and it compresses the brain. It pushes the uncus down, which presses again on the third nerve and then causes pupillary dilatation. So that's how you know the person's herniating. And of course, associated with that, there would be other signs. There would be a drop in conscious level. There would be posturing. There would be a reduced in communication. All those signs would be there. So there are different stages of that. We won't go into the details of that. And then there is a kind of herniation. Now, if you have a lesion on the side like this, you get an uncal herniation. But if you have a lesion on top here, which is not shown in this image, it won't cause uncal herniation. So it's going to cause what is called a central herniation, where both sides of the brain herniate together. Now that's equally bad, and that's bad because you get less time than an uncal herniation to make the diagnosis. A central herniation, you will not typically see pupils dilate ipsilateral and then contralateral and both pupils, and you won't get that typical sequence of events. It's going to be quite rapid, and you get both pupils suddenly dilating. And you won't get much time with that. So central herniations, in a way, is a worse prognosis than uncal herniations. And the last one that you have of the downward herniations is the cerebellar tonsillar herniation. You usually see this in a posterior fossa mass, if there's a tumor or a hematoma or injury or anything there, even in infarcts, ischemic strokes. You can have a tonsil of the brain herniating down there. And you can have chronic tonsillar herniations, because that you see something like that in Chiari malformation. Okay, so a tonsillar herniation can be acute or chronic. Everything else is usually acute. And then if you have a mass in the posterior fossa here with hydrocephalus, and sometimes we put in a shunt or a tube to divert the CSF outwards, and then you can have this mass push the cerebellum upwards. That's called the upward herniation. Extremely rare. You can just be aware of it. We probably won't be tested on that. With these herniations, we need to have some sort of a scale to objectify the clinical condition of the patient. And this is the Glasgow Coma Scale. You'll probably learn more about it in your clinical setting. I won't go too much into the details of this, but basically, 15 is the best score that you get. It looks at three basic responses. It's eye-opening, verbal response, and motor response. The best response is 15. The worst is 3. You don't get a score less than 3. That's 1 for each. And one of the most important problems with the Glasgow Coma Scale is that it does not take into account brainstem signs. So you don't have pupils, you have eye opening. You have a verbal response. So you can have a small stroke somewhere and you can have a bad GCS, but the person could be completely conscious. Or you can, so there are certain parts of the GCS which aren't perfect, but it was initially described for traumatic brain injury, but it's been used to evaluate patients with all kinds of intracranial problems, including tumors and hematomas and everything. Okay. Now, two aspects of the Glasgow Coma Scale when we yeah, I just wanted to mention this, is the posturing, which you see in a poor motor response. Now, this is indirectly tells you that the brainstem is getting involved. Okay, it's not a direct clue to the brainstem getting involved, but it's an indirect way. Now, you have an abnormal flexion, which is here, okay, and then you have an abnormal extension. So that gives you a motor response of 2 and 3. Now, what these two mean is the first one's called decorticate posturing or decorticate rigidity. It's an abnormal posturing in which the arms are flexed and brought towards the center, the legs are extended, and the feet, and they're internally rotated, and the feet are plantar flexed. So just, yes. And if you remember that the arms, because people have difficulty remembering which ones decorticate and which ones decerebrate. So decorticate, if you remember with this mnemonic, that the arms are brought to the core, to the center of the body. So it's the core and you have corticate. So that's one way to remember this. What basically is happening here is that the corticospinal tract effects on the body are being taken off. And it's the red nucleus and the rubrospinal tract which takes over. So if you remember from our discussion of the midbrain, the rubrospinal tract specifically affects flexion response in the upper limbs. So once that becomes active, it's usually not active, but in this situation it becomes active and you get a flexion response, showing that the corticospinal tract isn't functioning well, but it's the rubrospinal tract which takes over. So this shows you that the lesion is physiologically above the level of the red nucleus. So it's above the midbrain. Okay. The other one is called decerebrate rigidity or decerebrate posturing. And you can see in this one, the arms are extended and adducted out, and there's some pronation. The feet are very similar to the decorticate, but they're plantar flexed. I'm sorry, just that's it. I thought there was one more image. So the way I would remember this would be all the E's you have. So it's E for extension, and you have all these E's in decerebrate. So that's one way to remember which one's which. Now in decerebrate posturing, it's supposed to be worse than decorticate a little bit because you have the rubrospinal effects taken off. So it's affecting the middle of the spinal cord. It's below the midbrain. That's what it means, yes.
So what is stimulating the patient to
Yes, I was going to come to that. So usually the initial scale was described, because these are both part of the Glasgow Coma Scale. Now, this was initially described in people where you would give some sort of a pain stimulation, but you can see both responses spontaneously. And a spontaneous response is considered a shade worse than a response to a stimulus. So you can make a loud sound, call out the patient's name, and they could show posturing. Or you could just tap them gently and they would show posturing. Or they could do it spontaneously. So spontaneously is the worst. Okay, but that's not a strict criteria. Both these imply that the patient's doing really badly, and the prognosis is quite bad. It's usually, both posturings are usually pre-terminal. So they're not going to do well. So it kind of helps you decide on how this particular patient is going to do. The outcome is usually bad in both.
I guess the thing I'm so confused about is, like, we know the spinal tract causes a flexion.
Mhm.
I know the vertebral spinal tract is getting loose as well as extension.
Yes.
If there's a lesion that's destroying the communication between the brainstem and your spinal cord, what tract is responsible for causing this lesion to extend? Is it a reflex?
It's a reflex, and it's occurring at the lower brainstem levels. It's below the, so the rubrospinal tract's not functioning at this level. Yeah. And yeah, I'll just skip this because we've already done that. And if there are no questions, Dr. Ulal will take up the review.
This is the last lecture from Dr. Barnani.
So thank you, everyone. It's been wonderful being here with all of you. And I'm flying back home tomorrow. So all the best for your exams.
He just says wonderful being with you because he didn't have good time with me. All right, thank you.
Yeah, okay. I'll use my, thank you. So, all right, I was waiting for your emails last night, till late last night. I said, okay, if you have any request for a particular review that you want me, but I did not hear any knock on my door. So finally I said, okay, because people have been coming to my office and asking me questions, and based on that I thought, okay, let me take up these 3 concepts which I thought needs to be a little bit reviewed. And it's not a lecture per se, but it's a review. So what I decided was to essentially review hydrocephalus, not the entire thing, but some key features, and then intracranial hematomas, and in fact, what you just now saw will be probably discussed again. And lastly, something about thalamus. And what you're seeing here on top, they're all, of course, this is MRI, this is MRI, these 2 are CT scans, right? Sorry? What happened? Oh, okay. Oh, okay, good. All right. You don't want, that's good, otherwise it will be distracting, right? I don't want you to know what the next slide is. Suspense. All right. So what you're seeing here and here are MRIs, and what you're seeing here and here are CT scans, right? By now you should be able to differentiate between them. Now, in this case, what you're seeing is a mid-sagittal section, and what is very obvious here is the ventricle is enlarged. And you're basically calling it hydrocephalus, because CSF is accumulated there, and that is secondary to a tumor that is sitting here just above the superior colliculus, maybe a pineal tumor or pineal-related tumor, so that is obstructed the aqueduct. Therefore, there could be hydrocephalus here. Now, this and this are different type of hematomas, and these hematomas you should be able to very quickly diagnose in most of the cases by looking at a CT scan, because this is so often done. So one is epidural, one is subdural. We'll get there. And this, what is this here? It's an ischemic, or maybe it's a hemorrhage there, a small little microhemorrhage maybe. But where do you think it is? This is the axial slice. There's a thalamus, right? It's axial slice. This is thalamus, okay? This internal capsule is here, okay? So in fact, even here, there's a slightly hyperdense area, okay? All right, we'll see all this very quickly. Now, in terms of hydrocephalus, the key things that you need to know, first of all, increased CSF. It doesn't say increased pressure. Well, most of the time we get confused. The moment you think of hydrocephalus, we always think of increased pressure. No one said it. I can see a surprise on your face, right? Because hydrocephalus is basically saying increased CSF and ventricular volumes. It could be increased pressure or normal pressure, right? So in terms of, most of the times we do talk about increased pressure. But normal pressure hydrocephalus is also important because it can be, it'll have quite interesting features, and I'll talk about that in a bit. So in terms of increased pressure, most of the time it's an obstruction somewhere. Aqueduct maybe, or foramen Monro maybe, wherever. So the obstruction to cerebrospinal fluid, therefore the pressure increases. Simple. We can also have non-obstructive type, and we call it communicating type. Again, there could be increased pressure if there is increased secretion, just like in glaucoma we talked about, right? Increased secretion or decreased absorption could also produce increased pressure. Simple. How about normal pressure? How can pressure be normal and we still have hydrocephalus? Any guesses? Yeah.
Brain deteriorates.
You could have, yeah, you said the brain deteriorates, or I would probably say it is atrophy of the brain. It could have atrophy of the cerebral cortex, dementia. We'll talk about dementias in next third of the lectures after the exam. We talk of dementias, Huntington disease. There is atrophy of the caudate nucleus. There's hydrocephalus. So you can have pressure not increasing, but still have ventricles enlarged. We can also have hydrocephalus where the white matter, not the gray matter, but white matter stretches for whatever reason, and therefore the volume increases. Because in the skull is like a closed cavity. When something disappears, something else occupies. So the CSF occupies. So you have hydrocephalus. Again, that is normal pressure. So in terms of normal pressure hydrocephalus, there are two types. One is gray matter problem, another is white matter problem. Very simple, okay? Let us not go into controversies. Gray matter problem is what you just now defined. For example, in dementia or something where there is atrophy of the cortex, therefore there is hydrocephalus ex vacuole, something like this, like a vacuum in the brain. So you're sucking, the atrophy occurs, therefore volume of the CSF increases. Another type, in fact, this is the real, what we call normal pressure hydrocephalus, where we do not know what the reason is. Probably there's decreased reabsorption. So reabsorption and the arachnoid granulation is decreased. Then you'll say if there's decreased absorption, they should increase pressure, right? But we do not know exactly what's happening. What people say is the process is so slow. It's not that it's occurring suddenly. The decreased absorption is slow, that there's a compensatory white matter or white tracts atrophy. White matter atrophy or white tracts atrophy, or they may get stretched or something. So there is decreased reabsorption. It's not an obstruction, decreased reabsorption. In one case, we have, when there's decreased reabsorption, you can have increased pressure. There's increased pressure type. Whereas here, we have decreased reabsorption, but there's no increased pressure because there is a compensatory white matter atrophy. And in fact, some people believe that there could be slightly increase, but then you don't record it. Very quickly, there's drop. Increase, compensated drop. Increase, compensated drop. Finally, therefore, there is normal pressure. So then why talk about all this? If there is normal pressure hydrocephalus, why talk about it? We'll talk about that very soon for reasons. Obstructive type, the one we talk about most often. If it's occurring early in childhood, then there is enough time. The fontanelles are not fused, therefore the skull diameter increases. You have severe headache, vomiting, papilledema. Then you can have sixth cranial nerve palsy. You can have cognitive impairment because brain gets atrophied because of increased pressure. And then they have the sunset signs. You've seen that vertical gaze affected in this case because of pineal gland involvement. Therefore, there's aqueduct obstruction. And then we have the superior vertical gaze involvement, sunsetting sign. We've seen this before, so I don't think need to go into that again. Treatment, various types. You can have, I don't want to talk with Dr. Dadlani being here because that is his livelihood every day. Okay, let me not remind him. Okay, normal pressure hydrocephalus, okay? Now this, let me spend a little time here. Now, in what we call normal pressure hydrocephalus, like I said, we do not really know exact reason, but there's no obstruction. But the pressure is normal, the ventricles are enlarged, white matter is what probably is getting involved, gray matter is perfectly fine. Now what do we see in these patients? Typically occurs in elderly, okay? And because of compensatory white matter lesion, they have certain problems. And the problems could be depending upon where it is. There is ataxia of a particular type. We had never talked about this ataxia before. This type of ataxia is basically described as an unsteady gait. It's described characteristically as a magnetic gait. So if a person is standing like this, you ask him to walk. He walks as though his feet are touching the floor, okay? And he's not able to move them. This is how he walks. This is called magnetic gait. It may be confused with spastic gait or in corticospinal tract lesions. We'll not get there. But this is when you use the word magnetic gait, it is characteristic of this. As though the feet are glued, both the feet are glued to the floor. But that's not the only thing. You don't diagnose just based on that. They have dementia. White matter atrophy, and there's dementia. They also have urinary incontinence. That's what is shown in this cartoon here. The gentleman has urinary incontinence. And because of dementia, they are indifferent to that, and therefore they're called wobbly, wacky, and wet. Okay, ataxia, that is wobbly, wacky, they're indifferent and they have dementia and they're wet incontinence. Please remember, whenever you are talking about hydrocephalus with this triad, you're talking about normal pressure hydrocephalus. Okay, ataxia, dementia, and urinary incontinence. All right. Now, you may not get all the three so well characterized. Some of them may be more, some of them may be less, but typically when examined carefully, you'll see all these three. Now, why am I spending so much time on this? Because this is a hydrocephalus where, although the pressures were normal, okay, you tap a little bit of cerebrospinal fluid out of them. It's called, in fact, diagnostic tap test. You tap a few, although it's normal pressure, tap a few cc's of cerebrospinal fluid, immediately the gait disturbance improves. Almost diagnostic. Within a few minutes, right? Or maybe hours. The gait disturbance immediately improves very quickly. Dementia may not. You can do multiple examinations of the cognitive tests, and you can see whether it's improving. But that's why this is called treatable dementia. That's why people like to ask questions on this many times. Treatable dementia, because dementia, generally there's no treatment so far, right? But this one here, very quickly, within a few days, you start evaluating their mental functions, provided it's not very bad before, you find improvement there. So, diagnostic tap test and intracranial manometry, which will be normal. Neuroimaging, of course, will confirm CT with CT MRI, and you can have other localizing signs, but this is very, very important. Therefore, normal pressure hydrocephalus becomes important, the reason being it is treatable in terms of the dementia that is treatable, okay? And of course, we can also, we can leave a continuous shunt there, just like you do for obstructive hydrocephalus. Therefore, the patient, over a period of time, will show continuous improvement. So many of these people might do very well later on, okay? All right, review. Yes, please. Yeah. See here we are. She talked about communicating and non-communicating, right? So you can have non-communicating increased pressure, non-communicating normal pressure. Sorry, non-obstructive or communicating increased pressure or communicating normal pressure. All right. There are two axes. One is you're taking the pressure. Another is looking at the hydrocephalus. Yeah.
So then follow up to that. So with like an osmotic imbalance, would that fall under non-communicating or non-obstructive?
Osmotic imbalance, I don't think is related to hydrocephalus. You may have edema. Osmotic imbalance, I would. Hyponatremia leading to hydrocephalus, I don't think you can get, because we have got sufficient the blood-brain barrier to regulate the amount of fluid that's going into the ventricle. I don't think that edema should not cause hydrocephalus ordinarily. I mean, our hyponatremia or hypernatremia should not change the ventricular volumes. If at all, it could change the edema, the parenchyma can have edema there. Okay? Hydrocephalus should not be. I don't think it's related to that. Probably a little far-fetched.
So if you withdrew cc's of cerebrospinal fluid from a communicating hydrocephalus, would you see an immediate resolution of gait because you're decreasing?
Okay, in a communicating hydrocephalus, okay, so it's not obstructive, communicating hydrocephalus of normal pressure. Of increased pressure. Okay, yeah, of course, yes. If in increased pressure, your question is in increased pressure, if there's a gait disturbance, if you release the CSF pressure, will it help? Of course, yes. Yeah, of course. In fact, even an obstructive type, if you release the CSF pressure, you will have immediate improvement. Of course, yes. Yeah. But the point is here, you're talking of a patient with dementia, you don't expect recovery in dementia. That's the big thing. That's why you call it a treatable dementia. That's why you talk about that, okay? So be prepared for these type of things, all right? Now coming to the intracranial hematomas, why I decided I should talk about this or review this is because it's so very important. I want you to be very clear about this because you can see it's life and death issue, all right? I have a case. This is not a nip. 24-year-old baseball player incurred a head injury while batting. He felt a little dizzy for a few minutes, but was apparently fine after that. Okay, Felt if you for fine, then perfectly fine after that for some time. Continued to play for another half an hour. Soon after he retired to the change room, he was unable to walk and dropped down in a semi-conscious state. Oh, okay. He was quickly rushed to the hospital. He was restless. The emergency resident observed that he had a blood pressure of 130/90. So far he's fine. Respiration was normal. So far he's fine. There was paralysis on his left half. Okay. Babinski sign was positive on the left. Both the pupils were reacting currently. What may happen next? His left side is paralyzed. If there's a herniation, let us say uncle herniation, we just now talked. If the uncle herniation, I got my left side paralysis, where will the pupillary reflex be affected? On the right, because your oculomotor nerve is on the right side. Right side herniation has left to left side paralysis, has left to left side Babinski, and will have right side right side oculomotor nerve. Of course, later on, maybe the left also could be involved. Then you may have quadriplegia, that's a different thing, or paraplegia. But at the moment, his blood pressure is normal, respiration is normal, Babinski sign is only there on the left side, and pupils were reacting. Patient was disoriented in time and place. There was papilledema. Urgent CT was ordered. This is very, very important. He did a smart thing. Okay, urgent CT. Why CT? Why not MRI? Blood, fresh blood bleeding is best diagnosed by CT. Most of the time when I ask this question, people say MRI is expensive, very difficult to get. Who cares? You want to save him, you'll do it. But then CT is the best. In fact, gold standard. Don't go for MRI, okay? You need to have CT scan. And probably what has happened because of the injury there, he has bled his middle meningeal artery, or maybe vein sometimes. And you know, anatomical strategic location, that will not get there. It's in the pterion region, very easily ruptured, and could lead to epidural hematoma. Okay? Typically, at least textbooks talk about lucid interval. The lucid intervals could vary, so sometimes you may not see it, or it can have various types of patterns. But what is lucid interval? In 50% of the patients, the dizziness could be there, few minutes of normalcy. That's why they call it talk and die, and then very quickly they could have deterioration, depending upon how severe the bleed is, depending upon whether it's arterial or venous. Initially, there was because the dura mater is attached to the bone. So even if there's a rupture, the dura mater is tightly attached to the bone, so there's not so much of hemorrhage. So patient seems to be fine for some time. And then very quickly, the pressure keeps increasing, and now it's become quite a huge hematoma, okay? So please do not miss. This is the lucid interval when you should not miss. And then they could have, not in this patient had only contralateral paralysis and Babinski sign, here also loss of consciousness, and they could have pupillary manifestation, ipsilateral pupillary dilatation. It's also called Hutchinson's pupil. Some people call it that way, if you want to remember. So this patient is a different patient here. Right side pupillary dilatation, and she had left side paralysis. Okay, please remember that. There is a terminology that's used, coning, in neurosurgeon's language, where, like he was talking about, you can have herniation, the entire thing coming down like a cone, and typically by this time probably even the medulla may be pressing on the foramina magnum, and respiratory problems could be there. Okay, the minutes of lucid interval could vary from minutes to hours, the time. Okay, but please do not miss. Typically, you are going to see a football-shaped biconvex hematoma on the CT scan. Why? Because the dura mater is tightly adherent to the bone, and there was a fracture, there was a bleed because the blood vessels are immediately injured, and therefore there's a bleeding. But then because the dura mater is attached to the bone, it does not give way. Therefore, you have one convex surface here, another convex surface is the skull itself. So you have got a biconvex shaped hematoma. It's a giveaway answer. Okay, epidural hematoma, football shaped opacity. Okay, and in this you're also looking at a slight midline shift. Okay, which we just now talked about. So in fact, quite a lot of overlap between the previous discussion and now. See here. Yes, please.
Can you explain why they have a Babinski sign?
Yeah, I'll explain to you why. I'll come to that. The question is, how do they explain the Babinski sign? I'll explain to you. In fact, right now, here, okay? Here is the hematoma. This is the dura mater. See? The dura mater is attached to the bone here, but because of the pressure here, the blood has pushed the dura mater away. That's why epidural, outside of the dura mater. This is one convex surface, this is other convex surface. Now what has happened? Uncus has herniated. Uncus, what is he doing? Is pressing on the peduncle, cerebral peduncle here. And that's where the oculomotor nerve is getting impinged. So I'm going to have ipsilateral Hutchinson pupil, dilated pupil, and this peduncle has got fibers, motor fibers, which are going to come down, and then they're going to cross in the medulla and go to the contralateral side, right? Therefore, I'll have contralateral Babinski, contralateral paralysis, and ipsilateral Hutchinson, okay? All right. See, subtentorial herniation of uncus and compression of nerve 3 and blown pupil or Hutchinson pupil as it's called, crus cerebri or cerebral peduncle being impinged, okay? All right. Contralateral Babinski. Treatment is almost, if you timely intervention, this is where the neurosurgeons feel very happy because most of the time patients survive. But if you don't do a timely intervention, we could lose the patients. That's why, please, this becomes therefore a high yield concept. See, you keep always thinking, why is something high yield on the exam? Something which you're going to see every day. And if it's life and death, why not? Right? So please be prepared. Okay? And it's quite easy to treat. Surgery is quite simple. You don't need a high, you need an experienced person, but you don't need a high technology there. Okay? Important, important, important. Right? Don't forget this. Now, we have another patient, 70-year-old. Now, this is older. Waxing and waning consciousness. So, you'll have patients in the ward. Sometimes they're talking, sometimes they're dull, sometimes they're talking, sometimes they're dull. So, attending neurologist of a senior residence was routinely examining a 75-year-old inmate who had a 5-year history of dementia. She noticed that the patient was looking very drowsy and disoriented. His gait was slightly unsteady. His motor power was slightly diminished on his left side. His blood pressure was normal. There was no history of seizure, because you want to know when there's trauma, or any other neurological symptom. Patient did not remember of having had any fall or head injury, because these are all patients who have most often elderly with dementia and all that, so they might forget, they might have trivial falls almost every other night. Going to the bathroom, they may fall, and they forget that they've fallen. So what could happen is, with this aging process, they are prone to develop something else. And that is what we're talking about here. We have discussed this before as well. These are the bridging veins which bridge between the surface of the cortex and they keep going to the sagittal sinus. So these are the bridging veins. Now, these bridging veins, okay, this is just for you to read if you want to, are constantly being stretched, of course. And once as the brain atrophies, you have been told about this in the class as well, as the brain atrophies, these veins get stretched more and more and more. And when they get stretched more and more and more, they're more prone to bleed anytime, okay? So what is going to happen again is, this is what it is, these are the bridging veins. If it is stretched too much, and then you have precipitated that with a fall, that could lead to hemorrhage. And this hemorrhage now is subdural hemorrhage, because these are all in subdural spaces. So what's going to happen there? You'll have, because it's underneath the dura mater, the outside is convex, the inside is convex as well. This is called a crescentric, or like a crescent, okay? Hematoma, a crescent, okay? So multiple, you could have multiple of this. See, for example, this patient, he has had one here, maybe they occurred at the same time, or maybe occurred a few days ago because of multiple falls. They might not be even knowing, because not something like the previous patient did not suddenly happen over a period of time, right? And then what happens? You may say, oh, okay, so what if there is hematoma? Over a period of time, it can have osmotic effect in the local adjacent parenchyma, and that could lead to problems. That's why you need to treat them. If you're diagnosed, if the person is otherwise healthy, probably treat them. Okay, crescent shaped, some people call it the banana shaped, whatever it is subdural hematoma. Okay, please remember this. Very easily treated, most often does not bring about midline shift, but in this case it has been, the midline shift has been there. Okay, midline shift is a very important thing for neurosurgeons. They'll always keep looking for it, right? When there's midline shift, that means there could be subfalcine herniation, there could be other complications. So it's the severity of the shift, of the herniation is also quite a lot determined by the midline shift. Okay. You could have a lucid interval in these people as well, just like an epidural, but generally here the lucid interval is long, months to years, so you may miss it. So typically we use lucid interval in the context of epidural hematomas. So these are chronic subdural hematoma. Of course, be aware that very rarely you can have a shaken baby syndrome, child abuse, because the veins are again the same thing, right? I mean, you can imagine, all right? All right, you can also have acute subdural hematomas, just like the acute epidural hematomas, where everything is quite rapid and we may almost have a similar history like the case of epidural hematoma, okay? All right. Now, a third one is thalamus. Now, I'm not going to the entire thalamus because I assume that most of thalamus you know, so I'll take the advantage of that and then quickly come to some important things. You should be able to identify thalamus by this time, okay? Otherwise, please look at the axial slices and be familiar with that. Don't mix up thalamus. If you're not, let me help you out. How do I know this is anterior, this is posterior? How do you know this is anterior, this is posterior? Look at the ventricles. See? This is the anterior horn. This is the posterior horn of lateral ventricle. And once you see that, you're going to see the septum pellucidum there. Everything else comes up, okay? And then this is thalamus posteriorly. This is the thalamus here. And here in front, this is the caudate nucleus, which I'm going to talk about when I get to basal ganglia lecture after the exams. And this is the internal capsule, okay? Internal capsule, right? All right, let us talk briefly about thalamus. See? This is the internal capsule. This is the caudate nucleus. This is the thalamus. This is the corpus callosum. Okay. This is septum. What is this one here? Fornix. What did you say? No, yeah. Okay, doesn't matter. There's the fornix, okay? This is the corpus callosum. This is the septum. This is the fornix. What does fornix connect? Hippocampus with mammillary body. Okay, all right, good, good. Thalamus again. This is thalamus here, okay? All right. Now this is actually pulvinar, the largest of the thalamic nuclei, which you don't talk much about because you don't know much about it so far, all right? Now talking about thalamic nuclei, this is the left thalamus, by the way. Now this is thalamus, okay? So what you're seeing here in thalamus are multiple nuclei. Some of them you've already seen. You know, we have studied VPL for sure. We studied VPM for sure. We have not talked about VAVL. We'll see that after the exams. VPL, VPM, medial geniculate, lateral geniculate. We have studied all this. In fact, quite a number of these lateral nuclei we have studied. Remaining we are not, we'll see them later. Okay. This nucleus here, this one here is actually called internal medullary lamina. This is a Y-shaped sort of structure which goes through the thalamic nuclei. And inside the internal medullary lamina, we have nuclei as well. Now, these nuclei inside the internal medullary lamina keep arousal. They've got connections with reticular formation. Okay? What are the functions of thalamus? Let me slow down here because I've got time. What are the functions of thalamus? Why do you need a thalamus? Relay, wonderful, relay. But why do you need to relay? Isn't there a delay with relay? You want to organize, you want to connect. You want to connect the visual inputs, auditory inputs. You want to connect various things, so you need to have a relay. It's like a marketplace where you're bartering. Okay, you give me this, I give you that. So that's what's happening there. Okay, what else? Thalamus, very important function. Yeah? Keeps arousal through reticular formation. Then the very term thalamus is basically, the term etymology comes from hot bed. It's active, continuously activated. Visual inputs are coming in, auditory inputs are coming in, your touch sensations are coming in, whatnot. So many things are coming in constantly, and they go, your feelings, emotions, everything going to thalamus. So reticular formation is continuously activating thalamus, and that in turn activates the cortex. So thalamus is right there through which all the reticular formation fibers go. So in fact, the nuclei of thalamus are embedded within reticular formation. Okay? That being said, that Y-shaped structure that you're seeing, this internal medullary lamina, you can call it the highway for reticular formation. Think of it, I don't know what you want me to do. Just I want to tell you that. Basically, it's activating all the nuclei and activating the cortex. Now, why I'm telling you that is, if there is a stroke of the nuclei in the internal medullary lamina, unconsciousness, coma. Okay? So, lesioning the thalamus, particularly the internal medullary lamina or the nuclei within the internal medullary lamina, will lead to coma. Okay? So, there's so much the thalamus does. Okay, we'll talk about more about thalamus when we get to post-exam. When I start talking about limbic system learning and all that, we'll again talk of thalamus, because all these other nuclei are involved there. These nuclei we still not talked about. We are not talking about this anterior, not about middle dorsal, VAVL. We'll talk about all that. So, a special note on interlaminar nuclei. They relay dense and diffuse reciprocal projections to brainstem reticular formation to cortex, very important for arousal. Lesion of that leads to coma. Okay? Now that being said, last bit, you can have strokes of VPL and VPM. You're going to lose sensations because VPL, VPM are involved in somatosensations, pain sensations coming from the contralateral side. VPL for the limbs, VPM for the mouth, for the face, right? Of course, people lose sensations. That's the immediate effect. But unfortunately, when people have VPL, VPM strokes, over a period of time, there are some problems some people get into, and that's why we're talking about it here. They develop a condition which is called thalamic syndrome, also called thalamic pain syndrome. It has got other name also, but we'll not get there. It's called thalamic pain syndrome. What is actually happening is, although the thalamus has undergone a stroke and the neurons are damaged, there probably occurs incorrect connections that happen there or whatever. So what happens therefore is, people, although they don't feel sensations, what happens is, although there is hemianesthesia and an increase in threshold and delay in reaction to a painful stimulus, in Spanish it's called analgesia dolorosa, delayed pain sensation, and other sensations, often after several days during recovery, they develop thalamic syndrome. Hyperpathia, spontaneous agonizing pain, even without a stimulus. You've seen that in tabes dorsalis. If you're not, tabes dorsalis is one other condition where you can have these type of things. Dorsal column is damaged, and then also the posterior horn is also damaged over a period of time. So these people, sometimes there are neuropathic pain where without stimulus, they get excruciating pain. This is again typical of this. Hyperpathia or spontaneous agonizing pain. Allodynia, pain on trivial stimulus. It's paradoxical, right? You're saying there is no pain, there is no sensation, but then why do you get pain when there is a trivial stimulus? It's very difficult. This is typical of this so-called nociceptive pain or neurogenic pain. Pain is diffuse. Although it is one thalamus, it may have been right thalamus or left thalamus, but it becomes diffuse. Could even be triggered by things like music or something else. Okay, nothing related to touch. So, very poor prognosis and suicides are very high. Millions of dollars are being spent on research of thalamic pain syndrome. So far, we do not have a treatment. Okay, because we don't know what's happening. All right. With that, yes, please. Okay. Now, are these lacunar strokes? Yes, there could be lacunar strokes involved, especially in the interlaminar nucleus or intermediate nucleus of thalamus. Okay, so there could be lacunar strokes, but they could also be associated with large obstruction, or large, for example, posterior cerebral artery, because posterior cerebral artery is the one that supplies thalamus. So you can have posterior cerebral artery strokes. Bigger ones can also produce that, but lacunar could also produce. Okay, yeah. But you know what? When there's a bigger stroke, for example, if the entire thalamus is gone, the chances of living are very low, a very high fatality rate. So that's also a possibility, but these are all typically lacunar strokes. Because if thalamus is gone, I mean, the chances of survival are very, very low. Okay? So remember this nucleus, interlaminar nucleus. Okay, I've got that. All right, okay. Why am I going backwards? I've mentioned, you asked the question at appropriate time there. Posterior cerebral artery is the major blood supply to thalamus. It may get some blood vessels from the middle cerebral artery, but then the major blood supply is the deep branches of posterior cerebral artery. And that's what is involved here. Okay? That's all. Still have 5 minutes if you have any question that you want me to, any concept, anything. Yes, please.
Yesterday in the slides, in the midbrain section, the medial aspect of the lesion, they said the medial meniscus was involved, and I was wondering why that was.
In yesterday's lecture, you're talking about the medullary lesion, and in medulla, if the medial fibers are involved, the blood vessels, the paramedian blood vessels are involved. Why should?
Midbrain, excuse me. It was midbrain.
Yeah. Okay, in the midbrain? Yeah. Okay. What's the question?
The medial meniscus was involved, and I was wondering why.
See, what's happening is medial lemniscus actually starts as the question is, why should there be medial lemniscus involved when there are paramedian branches in the midbrain? It's very unlikely. It's not as distinct as it's in medulla, not as distinct as in pons, because what's happening is the medial, you're talking the medial lemniscus fibers, they started from dorsal column. Your pyramidal started from the ventral side. So as you go upwards, they start coming towards the peduncle. See, in the medulla, they're far there because dorsal column is far behind. Okay, then as you start coming to the pons, they're coming closer, and in the medulla, in the midbrain, they're coming close to the motor fibers. So as you start coming close to them, they go away from the paramedian blood vessels, but then still they are on the medial side. Okay, they're most often involved with the paramedian branches, where circumferential will involve typically the sensory, pure sensory, or maybe even the autonomic nervous system and all that. Okay.
They also travel laterally.
Yes, they come like that. See, in fact, it's something like in the medulla, it's something like this, folded hands, and then they start going more and more towards the ventral side, and they go lateral. Yeah. Okay. Right. Good. All right. See you. Do well. Sleep well. Eat well. Okay.